we're going to talk about everything from the UK variant to the cluster and contact tracing. And I guess we'll go ahead and start with the UK variant. Chima Mbakwe, he's the acting chief public health officer for the island of Guam. And then he's joined by the lab administrator for public health, Anne Marie Santos. Good morning.
Good morning.
Let's go ahead and talk about I guess we'll start with Anne Marie and talk about the process, right? Because we've heard with the California variant and the other samples we sent off to CDC. Can you kind of walk us through the process, Anne Marie, I mean, how we get these samples and what and when we decide to send off to the Centers for Disease Control?
So the COVID-19 response of the CDC laboratories, they had sent us a memorandum back in early January, late December of 2020, saying that we can submit samples for viral sequencing of SARS-CoV-2 positive samples. So since then, they do have the criteria. First of all, they require the CT value, which is the cycle threshold values, to be less than or equal to 28.
What is that in
CT
English?
value. So that's the lesser the number, the more viral, the more virus. So it'll only take like a couple of cycles to detect the positive virus. The more viral load there is, the less number of cycles that it will detect through the machine. So we are using our PCR machines and either the ABI 7500 or our Cephia Gene Expert. And so when a sample is positive, it has the numbers of the cycle threshold in the information from the machine. So from there, there's a metadata that we have to submit, and that metadata consists of 2 Excel spreadsheets. So one, it's called the global, it actually stands for Global File Accessioning Template. So it's called a GFAT. And so that should be emailed prior to sending the shipment. So CDC has to approve all the information that is in that metadata before we can ship. So we get prior approval for all the specimens and samples that we send.
So, Anne, let's say you swab me and I test positive. How much has to be done to my sample before you send it off to CDC? Because you talked a lot about like having to do the spins with the viral load. So I'm just trying to, layman's terms, is my sample after you take it from me and it's positive, is that good enough to send off, or do you have to spin it around in the machine more?
No, so your nasopharyngeal swab is processed directly into the machine once we have accessioned your patient information in our database. And so the barcode labels are printed, and it'll, from point A to point B to the machine, it'll have that unique identification number. And so once it gets in the machine, it has a report result, and we report it in a qualitative positive or negative. But for the machine itself, it has the CT values available. So that CT value will be the information that we give to CDC.
Let me ask you, so when we sent off these, and we'll just focus on the UK variant because it's the most recent, but when we sent off these UK variants to the CDC, we sent off 4 samples, 3 came back positive for the UK variant. When you guys send off these samples, do you already have kind of an idea of what you think it might be?
No idea at all.
So no one is looking at a patient and saying, man, this kind of seems like the UK variant. Let's go send a sample. It's just more like we're flying blind until we get the results back.
Not at all. Yes, we just submit the positives, and then, like I said, the CT value, and it has to be specific sample from the nasopharyngeal, collected in a viral transport medium, and that's it. just has to be positive and meet that value.
Yeah, it kind of seems like when we sent off the samples that eventually came back positive for the California variant, it seemed like it took way longer than the samples we sent for the UK variant. Was there a difference in the processing for these samples?
No, they were the same.
No, it was the same.
We would follow up with CDC, but the reason behind it is they do have lots of samples. Speak in a layman's term, they have many samples from all over the world that they do. So our samples are accessioned as it is received, and then they just had to look further into why it was in sequence. And I believe at one point they had to check the quality control values. And then, so they have their, like what we experienced last year, we had to recheck samples that we ran just to make sure that they meet the quality control and the quality control values
So with
and acceptability.
the latest, and I think it might have just seemed longer with the California variant because we were asking way more, and then we didn't even know that the UK variants were sent off for samples.
Another factor, possibly, we sent like 20 samples each time. And this, from the UK variant, that shipment was only 5 samples.
And so 3 came back positive for UK. The other 2 were just the general COVID-19.
Right.
Okay.
It was not a variant of concern.
But the UK variant is a variant of concern.
Yes.
Okay. And that is above a variant of interest in terms of seriousness and severity.
Yes.
Okay.
The transmissibility.
Right. Let's bring in, I don't know if this is a Chima question, but with the latest samples we sent off, because we were saying, we wanted to send these latest samples off to see if they were the India variant. We kind of had an idea why, right? So we had these doctors come back. Is this all related? Chima, I'm assuming it's related because it seems a little obvious.
So, like Anne-Marie stated, it's a process. We're part of that CDC process of sending in specimens to check, for what variants are in the community. So it's just a process. So we could have had the Indian variant, we could have had any other variant, but there's no way we can find out. So I think it's coincidental at this point that we had this 2 doctors test positive, and then we received this result. So it's coincidental. These are 2 different scenarios.
Yeah.
And like I stated earlier, the doctors took care of themselves, and we did not have any positive cases from for now, there's nobody that has tested positive from the contacts that they had. So even if there's any allusion that there's something going on right now, they are in isolation, they've taken care of themselves, and we don't have any person that is infected by them. So we're okay for now.
But also, Chima, we didn't know we had the UK variant out here until after the fact, right? So, I mean, we sent these doctors' results off to the CDC.
So it's just not about the doctors, it's about what Anne-Marie stated. If the CT values are high enough for us to send out.
Right.
So we actually do not pick and choose who. You're looking at the CT values. You're actually sending the identified information to CDC. So you're looking at a whole bunch of results. The ones that the CT values are enough for us to send out, we de-identify them and then just send them out to CDC. So it's more like it's a surveillance tool for us in public health, to use to find out what is going on in the community. So now that we've had this, now that we have these 3 cases, what we did yesterday, immediately we got the result yesterday, the team actually went back to review these individuals. So we We actually went and traced them back to when they got into the island, who they were exposed to make sure that, you know, within these 3 samples, nobody was infected. And we've been able to establish the fact that these individuals actually came from off island, were in the quarantine site. They were supposed to be released on day 6. They tested positive on day 6, and then they were put in isolation, and then their close contacts were quarantined for 14 days. So basically, they were quarantined for 20 days. So there was no transmission, in the sense that the individuals were tested, isolated correctly, their contacts isolated, and then they completed quarantine before they were released from the government quarantine facility. So for these 3 cases, there's a full assurance that nobody was exposed to these 3 individuals. And remember that in January, when the UK variant was discovered in the US in December of 2020, we met, and the director gave us his blessing to internally change our process. So we changed our quarantine and isolation process. Initially, we were able to identify people in isolation who had conducive homes. We could allow them, you know, isolate at home, considering the fact that we were trying to use the least restrictive measures on these individuals, like the way it is stated in the law. But when the variant was discovered in the US, we had to protect our island. And the only way to protect our island is anyone who is coming from outside who turns positive. We made sure that they went straight from the government quarantine site to the government isolation site. That way, we did not want to take the chance of introducing something different into the community. So we were able to isolate everyone who turned positive, and we've been doing this since January of 2021. So I think we are sure that these 3 cases, there was no community transmission based on these 3 cases.
All right. Let's talk about, are you ready to go into and then, oh wait, let me ask, how close are we to having the technology to be able to run these samples ourselves? Is that, because we've seen the technology through the course of this pandemic, it went from, you know, they had tests where it took overnight to get the results to now we got these super rapid tests. So you've seen like the evolution of technology in this short span of time. Is there any possibility that we could get equipment where we could analyze these samples on our own here? I mean, do we even have the personnel who do that kind of thing, Anne Marie?
Yes, we're building our capacity to perform sequencing. So we're working really closely together with our CDC partners and lab advisors under the ELC grant, the Epidemiology Laboratory Capacity Grants. We had submitted our budget, and it's for the justification for Guam Public Health Lab to set up like an ISEC 100 system, which is for a sequencing machine and all the related consumables that we will need to perform our own sequencing on island, so that results will be, improve the turnaround time for results.
Right.
So we're excited that we're going to be having that soon, hopefully. I'm not sure, hopefully by summer or before the school year starts for next fall.
Well, that is good news. And so it's just an equipment thing, like you could read the printout from sequencing?
Yes. So yeah, the analysis, of course, we're gonna, with the vendors, whoever is awarded the machine, we will get proper training, setup, validation, quality control measures. So we will be able to interpret the sequencing results as we do with the qualitative results.
Chima, let's go ahead and get into the We did have a comment here. What are the numbers of exempt travelers turning out positive after their arrival in Guam, including the two recent doctors? Because I know that happened with the guard. There was I want to say a couple. But is this something that you guys see every once in a while, Chima?
These are just rare cases. It's not, remember that everyone who comes in as a CSW has a pre-arrival test, and then they're also on restriction of movement. So even if they are, and they are monitored daily. So if they have symptoms, they report and go get tested. And when they are positive, it's easy for us to track because they are on restriction of movement.
Okay. So let's just jump into the cluster contact trace investigation for the A-Class Lounge, the infamous basketball game, and the Subaki Tower, Chima. Unmute.
Right now, there are no new cases identified since the 30th for the A-Class cluster. So to date, it's still those 14 cases. 13 of them have been released from isolation, and then one is still at GMH. So, and all the close contacts have been released. So that is basically closed. So closed in the sense that we don't have any cases coming out from there. But part of our responsibilities is to continue interviewing, to see if there are more links. But for now, within this period, there is no more positive cases, and then the close contacts have all been cleared.
For the A-Class Lounge cluster.
Yeah, the A-Class, okay. Yes. And for the Subaki cluster, one new case was identified on the 30th of April, but this was a patron, not a staff, and is currently in isolation. But the interesting thing is that this individual was identified in quarantine. So there is no new close contact for this individual. So, he was a close contact and was in quarantine and then was tested and turned positive. So if you're looking at the time he was exposed and the time he was in quarantine, he didn't have any contact with anybody to infect them. So this is like a stand-up, because what we normally do is you identify the index case, they name their close contacts, the close contacts are quarantined and then monitored. So at that point, you've actually cut off transmission, and then you've identified potential contacts, and then you monitor them, and then if they don't turn positive within the period of quarantine, then that is over for that particular case. So that is what we're seeing with this.
Unmute, Chima. I think you keep hitting that mute button. So let me just go back. There was a new positive with the Subaki Tower cluster. However, it was a customer of Subaki Tower who dined at the restaurants between April 14th and April 18th. Is that accurate?
Yes.
And so they were identified as a close contact. And then did you put them in the government quarantine facility, or were they told to just quarantine at home?
No, they quarantine at home.
Okay, so they quarantine at home, and then you guys were checking them. Hey, do you have symptoms? And was that when they were tested?
Yes, and then they got tested and they were positive. So because they were already in quarantine, they wouldn't have been exposed to some other person. So, yes, so
that's how you know that it's from Subaki.
Yes, but because, that's how we know that. Okay. It was a contact from Subaki. And then the whole 60 workplace employees who have been released from quarantine. The last close contact will be released tomorrow. So the 60 staff that were potentially exposed to this individual will be released tomorrow.
So we had 60 staff go through what? How many days quarantine?
14 days.
Wow. All at home?
Yes.
Man. And so none of them turned positives during that quarantine?
None of them turned positive, but we still have 1 day to go for some of them.
We laugh about the craziest things on this show. One more
No,
day,
but-
guys. One more day. So,
But I'm truly optimistic that so most of the exposures were minimal, but we were trying to err on the side of caution
Yeah.
to make sure that we do not expose more members of the community if something was going on. So the fact that the hotel was able to shut down and have all their staff in quarantine is a good gesture, and also some responsibility to the island, and we truly appreciate that partnership with them.
Right.
They didn't come back to argue with public health or try to fight us. They were very compliant.
let me ask Chima. So, going back to the customer of Subaki Tower who caught COVID from this cluster, what type of interaction did they have with the staff at the hotel that you believe that led to the transmission?
So the dynamics of this of COVID and airborne infections so we cannot establish if this individual was actually infected in Subaki or outside Subaki, right? So the reason is he was identified as being in a place a transmission was going on. So he might already be infected at the time he was in Subaki, right? So to make that determination is always difficult because you can't. There's no way for us to determine who infected each other. Is the index case you make the determination from who is the first person to test. So when you identify that index case, that is where you build your case from. It's like TB. For us, for TB, it might take you 2 to 3 years to identify the source of the source case, because we cannot actually do genome sequencing for TB, but that one you can actually do that, and then you're able to match up the strains and be able to build an AP link based on that. But now that we're in an epidemic, we don't have that capacity to trace because it's everywhere in the community.
I mean, but in interviewing this customer, there wasn't a point where he was like, "Oh, my mask was off," and it's something like this, and somebody spit one on me or whatever. There was no point in the investigation where you were able to look at anything that they had said and been like, "Oh, it might have been there, or it might have been happened there."
That you can actually ask those questions, but people remember very little over time.
Right. Yeah.
I don't think I can remember what happened last week when I ate outside.
Chima, so how many more people do we need to test out of the Subaki tower? Because I remember when you came on last week, it was something like there was over 1,000 people. So how far into that are we?
So like I said earlier, we actually asked. So those were the people identified by public health, and we asked them to go out to go get tested.
Right.
But we set up testing sites at the Northern Regional Community Health Center. We had the outreach at Tizen, and Subaki had the testing in their facility. But also remember that there are other testing sites on the island
Right.
that these individuals might have availed to. So we might have them. We might have the number that reported Subaki or a cluster on their intake forms, and there might be some who did not indicate that. But the fact is that we've actually seen an increase in number of people that have been tested within this period, showing that people actually went out to get tested.
Yeah.
So even if we don't get that mark of, even if we don't get to the mark that we actually identified, we also believe that people would have gone to other places to get tested. Yeah.
Right. So that doesn't necessarily mean that the positives we've seen over the last few days are necessarily connected to the clusters. They could just be separate COVID cases.
Yes, some of them are from the quarantine site. Some of them are actually other cases that they are close contacts in the family tested positive. Remember when I explained the concentric circle? So when you see one positive case in a family of, let's say, 6 people, and then we identify one individual that is positive, then we identify their close contacts. So there might be 5 close contacts. Those individuals will be quarantined, and then halfway into the quarantine, or if they develop symptoms, we'll go test them. So you might see 4 to 5 cases coming out from one household just for one exposure. So those close contacts are just part of one family cluster that is not a community cluster. So that is, so most of the numbers we were seeing last week, some of them were from the QFAC and some of them were close contacts to family members.
Wow. Chima, so let's say like I'm a close contact, and you guys tell me, hey, you got to quarantine for 14 days. What if I have like a job?
You need to quarantine if you are exposed. You need to talk to your employee, and then if your employee wants you to come to work knowing that you are exposed to someone who has COVID, I don't think that is possible. You know, considering the amount of information that we have out there,
Right, yeah.
because the consequence will be if the individual goes to work and is positive, then the individual is going to infect everybody in that establishment, and then everybody will be quarantined. So I think it will not be smart for
Right.
any individual to know that you're a close contact and allow you to come to work.
So was 60 Subaki staff that went on quarantine for 14 days?
Yes.
Wow.
Yeah, the hotel actually took the initiative to ask them to go home.
Wow.
Yeah, that is key in the sense that they were able to identify within themselves who they believed at that point were close contacts, and they were able to shut down.
Right.
That also helped in cutting off transmission, because if they've allowed them to come back to work, and the few individuals who might turn positive from that cluster who were part of the hotel would have created more
Yeah. No,
opportunities for
I get it.
transmission.
Yeah, I get it. I'm just wondering if there's ever been a conversation where somebody's like, how am I going to pay my rent if I got to miss work for 2 weeks? Because I know some of these employers, they won't even pay you. You're just SOL. But I want to say that if you get quarantined as a close contact, Shima, and you're out of work for 2 weeks, do you think you're eligible for PUA since your work loss is related to the virus?
I think I might not be in labor or DOA.
I know you're not. I'm just wondering offhand.
I can't answer those.
Right on. So Chima, last time you came on, you said we were still about a couple weeks out from really seeing all the effects of these different clusters and the close contacts and the investigation. Is that still accurate? When would we expect kind of like, not a finish line because I know the nature of the virus, but do we still need a couple weeks to let this kind of wash out and see what happens?
I always say that we are still in an epidemic, a pandemic, sorry. We're still in a pandemic. So because we are still in a pandemic, we can still see, sporadic cases here and there. But the most interesting thing is that we also need to make sure that we're doing the right thing to stop transmission in the community. So it's a balance. So like the last 2 weeks was an example of how one individual can become a super spreader, and create a problem. So it's us taking that initiative that we can become the problem in the community and adhere to the public health recommendations about keeping the community safe. That will be my answer, going down the line until the pandemic is off completely, is called off, until the island is fully vaccinated. We just can't sleep on. We can't rest. We continue to work towards making sure that we protect ourselves on the island.
All right. Thank you, Chima. Anne Marie, anything in closing?
Closing. Okay. Well, this week, actually, the lab team is preparing for another shipment of samples for sequencing. So for this shipment, we have a total of 25 samples being shipped out. We're working with Ambith Logistics, packing it in dry ice. So CDC did approve for these 25 samples to be sent. 5 of the 25 are travelers, 2 from the US, 2 from Manila, and the 1 from India. And the other 20 are local community swabs. So we're going to check for either from the cluster testing, and more information will be provided as soon as the other sequencing results will be.
Right. And then for the UK.
So we're always like, yes, every day we have a NS3 portal. They call the NS3 is the National SARS-CoV-2 strain surveillance program of CDC. And myself and Dr. Ann Pabutsky has access to that portal. And each morning we check that. And that's when yesterday we got the results of the 4 results that were available, in addition to the 26. So in total, we've shipped out 61 samples. 30 had been sequenced. And so 31 samples are waiting for results. And then we will add 25 to that number by the end of the week.
Okay. And then the takeaway, Chima, from what you're saying, the 3 cases, the UK variant, were stopped in the quarantine.
Yes, they were stopped in the quarantine. Yes.
Okay.
And I am confident that we did, because of the change in our internal protocols as of January 14.
Which of the variants, in your opinion, is the worst one, Chima?
You know, we just go of the classification of CDC. You know, so the one is the variant of high consequence. So that's basically what we can say is the one that is the worst. So right now we just have variants of concern, which we are really concerned about.
Yeah.
So.
You're not interested, you're concerned, but it's not a high consequence. That's the third one, Jake. Because we were talking about that, we knew there was variant of interest, variant of concern, but the top tier is variant of high consequence.
Yes.
Who thinks of this stuff? They couldn't come up with an easier one? Like,
you know, the thing is, you know, so the interesting thing now is, you know, trust. You know, this is a time people should trust public health. This is a time the community should trust the government, in the sense that, you know, we've been able to demonstrate, you know, that the policies, the recommendations, you know, have been able to put us where we are now, and you can imagine what public health has been able to do in the past 2 weeks, you know, with all these challenges that we have, and also making sure that the community is safe. So essentially, as we are looking at the technological solutions, which is the pharmaceuticals, you know, using the vaccine, you know, as another layer of protection, we also have to look at trust, which is about listening to our recommendation on behavioral change, you know, putting out there how we should behave right now, you know, open your windows, you know, wash your hands, wear your face mask. So this is a new norm, and this new norm and this new behavioral changes, we need to be able to have a level of trust that this will work for us in collaboration with the technological advances of the vaccine, so that, you know, it's difficult, but I just see, you know, how people would need to behave, you know, how they process information now, you know, how we tend to move from here forward. So I think it's important to build that trust, and I think we've gotten to a point where the response, which is public health and the government, you know, should be trusted, and people will be able to continue following our recommendations until we're out of the woods. Because I think I'm not the one that, normally beats my own drums, but I can say that public health at this point has shown, a lot of resilience. We've shown a lot of commitment. We've been overstretched. But at the end of the day, where we are today is the commitment of public health and the community. But so we just need to continue having that commitment and that trust until we're sure that everyone is vaccinated and we are safer than we are before. Then we can relax relax, but not relax our defenses.
Right on. Chima, I agree. I think that public health has done a pretty damn good job. And the community as well. Trusting the government, that's a conversation for a whole other show. Chima.
Well, public health is part of the government.
I
so
get
that's
you.
why,
I know.
yeah.
Right on.
Yeah, that's the government.
Okay, my friend. Anne-Marie, thank you. Come back anytime. It was fun, right?
Thank you.
Right.
Right on. There you
Thank
go.
you.
I'll see you guys. Chima Mbakwem, the Chief Public Health Officer, joined there by the Public Health's top lab administrator.